It's Teresa Brockie. I am Ani from the Fort Belknap Reservation in Montana and an assistant professor at Johns Hopkins School of Nursing. I am clinically trained as a public health nurse, a fellow in the American Academy of Nursing, and serve as co-chair for this planning committee. Thank you for your attendance, and looking back, thank you, Ms. Fowler, for your opening remarks, and thank you, Drs. Bigfoot, Houses, and Warren for your panel presentations on exploring epidemiology of suicide trends. We will start the panel discussion. To our first question, and I'll leave it open for whoever wants to start. What is the connection between suicide prevention among Indigenous communities to improve social situations and reducing social disparities among Indigenous groups of people around the world?
Actually, I'd volunteer Dr. Bigfoot to share her thoughts, if that's okay.
Can you repeat the question? I'm trying to figure out which part to.
It almost feels like there are two questions in there.
Yeah.
So what is the connection between suicide prevention among Indigenous communities to improving social situations and reducing social disparities?
Well, I'm wondering about the social situations and social disparities. I think that when we really look at this, the slides that were presented, we can really see the conditions that are affecting our American Indian and Alaska Native families and communities. And I know an elder said that when a tragedy happens and you're on the ground, that when you look for help, you don't assess what kind of help it is. You just think that whatever is there will help. And sometimes whatever is there isn't that helpful. A great uncle in the family said the things that were presented to our community were, alcohol, guns, despair, and also religion. Or organized religion, and that when you look at what was being offered in those moments of high despair, high disruption, how helpful were those things? And that it takes several generations. That when we think about the seventh generation model, that it takes a while for people to be able to reassess how well they're incorporating information. And so when we have better resources, when I think about the last 26 months or so of the pandemic, I had really good resources. I had a home, I had good internet. I had, delivery service for groceries. I was in a very privileged situation. And so our little family bubble, and we could create a family bubble, a 3-generation family bubble that allowed us to be well protected. I had good resources. So when we think about, what is not working, how well do our communities have resources? How well do family members who do they have to turn to? And so I think as we look at, what is those social disparities, they're generational in nature. How do we help break those disparities? How do we create? We had another conversation earlier this week on another panel presentation, and understanding how economic viability is so important. Being able to afford food, being able to afford a home, being able to afford transportation. So, how do we connect economic viability and social disparities and adverse childhood experiences, and understand how historical trauma has impacted our communities? One of the things that we have been implementing a lot of is recognition of land acknowledgement. And we saw a lot of the how much our Indigenous land does not fall within the tribal jurisdiction anymore. And when we think about what was the essence, as we think about that, being able to have territory, being able to have access to harvesting, being able to have access to hunting, being able to have access to building homes. When we think about land acknowledgement, it really is about safety, about seeking protection, about having alliances, about being able to rely on someone. And I think that we need to have a broader perspective of what is meaningful in that whole realm of social, emotional, spiritual, intellectual, and relationships, and the bigger picture of how safe our families, how much safety is there in our communities when there's been such disparities, and people don't do well when there's a lot of despair. They don't think well. They don't consider long-term consequences to their actions. And I think one of the things is that people want to stop suffering. That suffering is huge. People want to stop suffering. Individuals want to stop suffering. How do we look at what caused the suffering in the first place, and which part of their humanness, which part of their sacredness, has the most suffering, and how do we help bring that sacredness back into their lives so that they don't have that despair and the desire to end their sacredness. All right, Don, Emily, jump in.
Hey, go ahead, Emily.
Well, I think that the question is really interesting because for me, it suggests this cause and effect relationship. Like if there are social situations that create social disparities that lead to suicide in the community, when it's actually much bigger than that. There is historical context, and there are structural issues. And you can't really say we're going to do an intervention with the family that will eliminate or that will address ACEs in a family, and therefore we will take away suicide in the community, because that doesn't fix what's actually happening in the community. It has to go much deeper than that.
Yeah, I would agree with that we have to recognize that there's a historical and social context that leads to risk for these circumstances that the kids are growing up in. But we also have to recognize that the lack of resources and poverty is also a risk factor. So we have to have a much broader perspective on public health interventions, and even recognizing that economic development and workforce development are public health interventions. So we have to have a much more comprehensive and holistic approach. It will take a generation to do this work effectively, but we need to start stepping in those directions, and we need more Indigenous peoples leading the effort, conducting the research and developing and implementing the programs.
We can move on to the next question, and we might start with Dr. Jesus on this one. So is there a data repository for this type of data or a national database utilized for American Indian and Alaska Native data?
It's a very complicated question because you're starting to toe into issues of data sovereignty. So the general answer is you can go to CDC Wonder, and that is a general data repository. So if you just Google CDC Wonder, you can start to tool around and find a lot of data that exists that will give you statistics about mortality and incidence and prevalence and all that business. You can also go to SEERS, which is the Surveillance Epidemiology and End Result, to look at cancer statistics. There are lots of different federal databases that you can look at. But the caveat is that tribes do not, they don't participate in how those data are collected, how those data are reported. And so it's, you don't know how accurate they are. The SEER database actually has a special site where you can go and get the PRCDA data set separate, which is nice. That's surveillance, epidemiology, and end results. So that's just cancer data. But with CDC Wonder, it's not necessarily all native data. It's not the PRCDA data. You have to be on the inside track to get that. And if you want to be, if you want to honor tribal sovereignty, you need to go to the tribes and establish those linkages and work closely and talk to tribal councils and find out what's happening within the tribes, which is a whole other day of meetings, because that's a real complicated issue. Yeah, I guess I'll leave it there because I don't want to start wandering down that road.
Just to add a little bit to this, I'm sorry Abigail Echohawk couldn't be on this call, but you know, the Seattle Indian Health Board and the epicenter is trying to, and I'm speaking, you know, I'm speaking with from someone that's not as familiar with that, but they are trying to gather as much public data as possible, and but recognizing that tribes are sovereign nations and they have a right to determine how their information is gathered and where it is housed and who has access to it. But for public information, you know, well, I think where would those resources be at? And the Seattle Indian Health Board is one place, but those epicenters are another
Yes.
opportunity. So
why did I even forget about that? I work with tribal epicenters. So yeah, if you Google tribal epidemiology centers, there's they're regionally based, and they do a lot of the work of working with tribes to make sure that the data that they have is good, ethical data that has been vetted by tribes. But again, they're going to work with you after you've worked with a tribe. So you have to have relationships with tribe to access those data.
Dr. Warren, do you have anything to add?
You see, the only thing I would add is that you know, we do have a lot of data, obviously, within Indian Health Service, but it's also important to remember that not all American Indians use Indian Health Service. I'm one who doesn't, for example, because I have insurance and I live in a city where there's no urban Indian clinic. So we just have to be cognizant of the data sets that we're looking at and understand, you know, what is the denominator that we're really looking at, and we just have to be careful when comparing data sets and recognize that there's no single data set that captures all of us.
So great. We'll move on to the next question. What kind of resources can we give those who feel like they've lost their sense of cultural identity and want to incorporate traditions and are seeking mental health services?
I guess I could try to take the first effort to answer that. That's really challenging because each community is so different. So some communities have real strong connectedness to traditional healers and cultural and knowledge bearers, but not every community has that. So I think it's important to look at what are the assets within each community. And the diversity of tribes and indigenous populations is tremendous. So there's not a single approach that would be effective. I think what's really important is to have community champions that can lead the efforts, but also really being aware of the assets, the local traditional healers and cultural leaders, because that's such an important component of the healing process. But not every community has access to those resources, unfortunately. So I think there's we just have to really take an inventory and understand what are the resources available and how might we best work with our traditional people.
I'll add in that if you're in an urban center or in a major city, there are often urban Indian centers where you can start that journey if you reach out and start asking questions. But you have to be respectful. You have to do your homework. You can't just walk in and say, hey, I think my great somebody or other was something. So can you teach me? You have to start with yourself.
I'm really always grateful that the Cheyenne people allowed me to continue to be part of their community after my children's father died, and to embrace me. I think one of the things that our tribal communities are is very welcoming, and that respectfulness is a key part. I would say, in addition to what Don and Emily has said, to also think about where people are enrolled at. There's if someone is enrolled, or if they know family members that had that connection of enrollment at some point in time, that's one way to connect is follow that enrollment. Most tribes have websites, so there's if you have internet access, there's that also, and there's a lot of universities. For example, I'm at the University of Oklahoma. They have the Western History Collection and also the Sam Noble collection. I can't remember what it is, but they're digitizing a lot of their records. The Smithsonian has also digitized a lot of their records. So right now we have a lot of information that's available through the internet that allows for exploring, histories and what might be there historically. But it's always helpful to have a person that you can talk to. So whoever might be, we have. I'll probably pronounce her name wrong. Sandy, Hearts of the Hawk. She's a wonderful elder that would probably talk to anybody and everybody, and people can take joy in her knowledge and in her sense of welcome for everyone. So as we think about what's available, there's a lot of different roads, pathways, different journeys that are possible because the information is much more readily available than it was before. I think a lot of times we have a lot of families that have histories that are heartbreaking, and that people find it really hard to read about their family histories. But think about it, there's those of us that are still here today that have managed to thrive. And I remember meeting Emily's grandfather, being in Oklahoma, and I didn't know me, but certainly the strength and the presence of his blessing and his artistic talent, and just this quietness that he offered. I remember that. So as we think about how do we help with this connectiveness, it's recognizing that we have those family members or those relatives that we can reach out to. Maybe they're not biologically connected, but there is that presence. And there's lots of stories about finding lost children. There's lots of accounts of how people went about finding lost children. So as we think about individuals who have been marginalized, or and a lot of these are coming up through the child welfare system, or being adopted out, or relocation, or just being the only tribal family living in a community. So how do we reach out to those relatives and welcome them back in, those lost relatives? So I think there's those stories that we can bring to bear and utilize those kinds of cultural strength to think about building relationships and using that in a preventative ways. So I think we have a lot of opportunities. They might not necessarily be the more traditional way of bringing relatives in, but the internet is a tool that we can certainly utilize.
So thank you. The next question, I think, Dr. Warren, we can start with you. Please provide examples of incorporating culturally appropriate practices into currently proven suicide prevention efforts. Is there a plan to build an evidence base to evaluate the updated practices?
Yeah, and then there's actually two really important parts to that question. One is related to what's going on now, and the other is evidence-based. And one of the challenges that we face is, obviously we want to focus on evidence-based practices, but my question is always, whose evidence is it? That if a program is working effectively in Boston or Atlanta, does that translate to Pine Ridge or Fort Apache? It may or it may not. So we do need to build the evidence base of our interventions. The challenge that I see also is that we've had Indigenous ways of knowing. We've had Indigenous research methods. We've had Indigenous evaluation frameworks. But we're being forced to make Indigenous approaches fit into a colonized perspective of evaluation and research. And it doesn't always work. Just as a quick example, our gold standard for research is the randomized controlled trial, right? So it's fine to use a randomized controlled trial if you're studying a pill, because it's easy to make a placebo and look at the effect over time. But how do you placebo control ceremony? What is a placebo control for Sundance? What is a placebo control for prayer? And there aren't any. So we get criticized for our interventions for not being evidence-based or published in scientific journals. But in truth, our interventions are more dynamic than a pill. And we need something more than a pill to work. So the challenge is not a limitation of our interventions as Indigenous people. The challenge is the limitation of the mechanisms by which we evaluate our interventions. The shortcoming is on the colonizer side, not ours. So what I observe is really effective programming that incorporate language, culture, engaging across generations, youth and elders, And I know those people are safe relative to those who are not culturally connected. There is a protective effect of culture that we see. And there are some studies that look at this, but I think we have to be smarter. And I think even through National Academy of Science and Math and looking at, or Science and Medicine and recognizing that if we're going to take the same old approach to evaluating Indigenous interventions, we're going to keep failing. We need to be smarter and use Indigenous methodologies to establish our evidence base, because we have different ways of interventions and different ways of knowing and different methodologies. So that's a long answer to a relatively straightforward question, but it's incredibly complex. So we just need to we need to be open-minded enough to embrace Indigenous methodologies to establish our evidence base. Thank
you, Dr. Warren. I wonder if we can just assign these questions to try to get to as many as possible as our time is winding down. So I will ask Dr. Houses to answer, if she can, the next question. What, if any, are some programs available for urban American Indian Alaska Native youth that encompass suicide prevention and substance use and a substance use component? Thank you.
I am having a little moment of brain deadness. I'm going to pass this over to somebody like Dr. Bigfoot, because I know she's got a whole program. So if somebody else wants to jump in.
Thank you. Yes, I think that there's a lot of culturally enhanced evidence-based practices that we can consider. I just like to back up a little bit and reinforce what Dawn has said about what kind of evidence. So I think we need to appreciate the test of time evidence that has allowed us to have a lot of cultural practices. I mean, we look at the canoe. The canoe hasn't been really the shape of the canoe hasn't really been changed. The material, and maybe who makes it and how you make it, but the canoe itself has maintained the same shape, for hundreds and thousands of years. The drum, how the drum is made, so there's things that we can look at that have stood the test of time. So there are things that have stood the test of time, and then there are, teachings that have stood the test of time. And as we look at smudging, that has, continued onward, and the understanding of grounding, centering, mindfulness, that has evolved in terms of the terminology, but the practice of how to center, the practice of mindfulness, the practice of has been here for generations and has stood the test of time. So I think we need to challenge what kind of evidence there is. Given that, there are also the appreciation that we want things to work in our tribal communities. We have for so long had a lot of practices that did not work, or interpretations of behaviors or life ways that were seen as peculiar or misinterpreted. The meaning of them, totally off track based on a Western orientation. And so how do we look at evidence-based practices or evidence-based approaches? And, I like being able to have, new lens put in my eyes. I like being able to have new knees, and I like a car that is reliable, and I like to know that the airplane that I get on is going to be, take off and land safely. All of those things are evidence-based practice. So we build into our life, the internet, all of this is evidence-based practices. So how do we take things that are evidence-based and make them work within our communities? one of those, and I put it on there, is honoring children, many of the circle is a cultural enhancement of trauma-focused cognitive behavior therapy. It works. We have therapists that have been doing this for, years, and we see the decrease. This is one child at a time, unfortunately. But what can we do so that we have preventative factors rather than remedial, and try to bring children back? It's effective. So there's a lot of varied evidence-based models that have been culturally enhanced or modified in order to be more suited for American Indians. There's, things that haven't worked. The Prevent Child Abuse America developed the child abuse. Can't even remember what it was, but I worked on it. I'm getting too old, and it didn't work. It didn't work in Indian communities. So how do we find things that work and things that need to be modified and things that are just not effective? But we can utilize tools that make sense. So Dawn said earlier that cognitive behavioral model. We have always been thinkers. We understand how to think. We understand behaviors. I mean, when we think about early on the way that birds of prey were trained to capture rodents and other things and to bring them back, that's all about behavioral modification. So we understood thinking, feelings, affect regulation. Wiping over the tears is all about affect. So thinking, feeling, behavior, those are principles we knew early on. So how do we look at these things that have those principles that we understand and can apply it within our cultural framework in a way that makes sense? And I think there's a lot of things, I talked about that great mystery that's out there. There's a lot of things we can't explain, but what can we do that and work with things that we can explain? And so as we think about evidence-based practice, I think it falls in different kind of categories. And so I think that's on us as in academia or in research or whatever, is to help our communities learn how to assess what can work and how to make adjustments. I think that's on us to be the instructors on evidence-based practices.
Thank you, Dr. Warren, Dr. Bigfoot, and Dr. Houses. We are now moving into a break.